Bain and the BIA main chapter. Today's topic is accommodations for treatment of co-occurring TBI and substance use in group settings. The BIA main chapter gratefully acknowledges partial support for this training series from the Administration for Community Living, the U.S. Department of Health and Human Services, and the Maine Department of Health and Human Services. To ask a question, please type it in the Q&A box of your control panel, and at the conclusion of the presentation, I will read as many of these as possible to our presenter. Our presenter is Dr. Crystal Fullen, a clinical neuropsychologist serving the Department of Psychiatry, Neurology, and Trauma Surgery at the University of Arkansas for Medical Sciences. In her role, she has developed and co-directs a multi-tier cognitive rehabilitation program at the hospital to foster interdisciplinary inpatient and outpatient rehabilitation of cognitive dysfunction, primarily in a TBI population, which also includes behavioral management of post-injury psychiatric symptoms, family psychoeducation to improve recovery, and brief psychotherapy to improve adjustments to injury outcomes. Welcome, Crystal.
Thank you so much, Peggy, and good morning, everybody. I'm so happy to be here with you on this Monday morning. Today, as Peggy mentioned, we're going to be talking about accommodations for treating people who are diagnosed with both traumatic brain injury and substance use. And we're really going to focus on accommodating or making strategic changes to typical treatments in order to improve the therapeutic relationship, in order to improve how much outcomes patients are getting from treatments in group therapy settings, or just in general settings where you're seeing multiple patients at one time. So I'm going to move my slide up. Here is an announcement from the Brain Injury Association of America that you'll also have on your slides, and ways that you can get in touch with the Brain Injury Association of America if you need to for any additional information. All right, let's talk about the objectives. So things that we want to make sure that we are able to go through together today. So the first one is really working to understand the impact of comorbid TBI and substance use disorder, or SUDs, on behavior in group therapy. We also want to focus on identifying common and intrusive and challenging behaviors that really stem from the collection of symptoms in brain injury and SUDs. The third thing that we're going to work on today is developing strategies for managing things like agitation and really just managing any other challenging behaviors that occurs because of these diagnoses. And then we're going to talk about how we can promote therapeutic engagement, and participation in therapies by using accommodations for these folks. And then last but not least, because working with brain injury and comorbid SUDs can be very challenging for clinicians, we're also going to talk a little bit about how to enhance clinician self-regulation, awareness of things like burnout, and strategies to improve clinician wellness. Okay. All right, I always think it's nice when you have a presenter that can kind of share a little bit about themselves so that you can get to know me. So my name is Crystal. I'm a clinical neuropsychologist. I currently live and work in Arkansas. I'm not originally from Arkansas. I'm actually from South Africa. I moved here about 19 years ago to the United States. I actually serve the brain injury population at two hospitals here. One is an academic medical center, and the other, Baptist, is an acute rehab setting where we see people pretty much immediately after injury once they're medically cleared, and work with them and an intensive rehab team to help promote recovery as much as possible. What I do is really neuropsychological assessment and rehabilitation, and I do that primarily inpatient. I don't do much outpatient work anymore. My expertise is in traumatic brain injury and rehabilitation, and to that end, I do a lot of consultation and program development in the state and then nationally to help support people who are serving brain injury survivors, and what that kind of looks like for not just the clinicians who serve them, but the patients and then their families as well. And that picture is of me and my dog, Apollo. This was taken at one of the local MS walks. I take Apollo with me everywhere. I wish he could be here today. He's a great therapy dog, if you will. He's actually just a major goofball, but he's a big Great Dane. He's 160 pounds, so people love getting to meet him. All right, so seems like my slides are moving a little bit weird. So you should be seeing a brain. Okay, so let's start by talking a little bit about SUDS and TBI, just a refresher about what we're looking at, what kind of symptoms we might expect, and why those symptoms happen. So with traumatic brain injury, or TBI, my favorite definition is a sort of combo definition from the CDC and the DoD that says that TBI is a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head, or a penetrating head injury with new onset or worsening of at least one of the following. So alteration of mental status, which could be confusion, things like neurologic deficits, or vision changes, loss of consciousness, those types of things, or intracranial lesions, so brain bleeds. Simply put, a TBI is a blow to the head from an external force, and we can have two types of injuries in that realm: open head injuries or closed head injuries. An open head injury would be when you have something like a gunshot wound to the head or a stabbing to the head, where that penetration actually breaks open the skull and the brain parenchyma, that brain tissue, is exposed to the external environs. Brains do not like that. And that makes people who have open head injuries at a pretty high risk for mortality. One of the big reasons for that is because when the brain is exposed, you have a very high risk of infection, an infection that can be pretty difficult to treat medically. We also have closed head injuries, and closed head injuries occur when people have things like falls or motor vehicle accidents, where the brain is sort of moving around in the skull in a way that the skull and the tissues and the cerebral spinal fluid just really can't protect the integrity of the brain. And so people get pretty badly injured from that as well. With closed head injuries, falls are pretty much the most common cause of closed brain injuries. And people at risk for falls happen kind of on the ends of the age spectrum. So younger children and older adults. So you'll see that pretty often. I also do want to say that some recent data that's come out by the CDC and other national entities that do a lot of stats on TBI have said that suicide is kind of starting to overtake falls as one of the leading causes of traumatic brain injury as well. The only difference for us as clinicians is that with completed suicides, we obviously don't see as many of those patients as we would patients who survive things like falls. Okay. So let's talk about how injury actually works. So we know we have this external blow to the head, this external force that's hit the brain and caused things to be disrupted. And so the way that we think about it is primary and secondary injury. With primary injury, what's happening is that's that initial blow, that first moment when the head gets hit, right? And that causes a disruption of how brain tissue really just works. They can be immediate bruising. They can be things like diffuse axonal injury, and there can be bleeding. Secondary injury mechanisms are also really important in TBI and actually cause a lot of what we end up treating after the fact. So secondary injury mechanisms is everything that happens hours to days after that first initial blow. And what we're looking at here are things like biochemical changes. We're looking at increased intracranial pressure. We're looking at cell death cascades, inflammation of the brain tissue, midline shift, and the possibility of multiple complications that can occur as a result of those secondary injury mechanisms. So those can be things like cranial nerve injury, things like seizures, things like hydrocephalus, where there's an issue with the absorption and the flow of spinal fluid in the brain, in and around the brain. So the severity of persistent symptoms that people struggle with after brain injury are actually most related to that secondary injury process. And so what acute treatment strives to do when people are in the hospital, in a trauma center, is to manage primary injury mechanisms to the degree that we're reducing that development of those secondary injury mechanisms and all of the complications that can follow from that. I want to make a note here that TBI is actually a pretty new field if we think about medicine as a whole. It wasn't really until the 60s, late 60s, early 70s, that people really started having the advent of medical procedures, surgical processes, treatment regimes that would actually help save people's lives who were coming in to hospitals with severe TBIs. And so as a result, our research on what we know people experience, on how the brain recovers from moderate to severe TBI is actually still fairly limited. It's only about 50 years old, which is kind of new for medicine broadly. And as a result of that, we're learning new things. I want to say one thing here about biochemical changes. There's a lot of studies coming out that actually indicate that one of the relationships between TBI and substance use disorder is that some of the biochemical changes we see as a secondary injury process after a brain injury is also seen when people are first exposed to certain substances like alcohol, cocaine, and cannabis. We see that same sort of biochemical neurotransmitter upsurge and change in the brain. And so when people have a TBI and they're also exposed either prior to that or after the fact to substance use disorder, what ends up happening is you have this doubling down of sort of brain function that is making people really susceptible to increased use, impulsive behaviors, and so on. Okay. All right, so with brain injury, regardless of the type of injury, be it open or closed, or how many complications someone has, that initial injury, that primary injury, is going to tell us a lot about the severity of someone's TBI. So we have a range from mild to severe, and there are multiple things that we use to help us determine if someone had a mild, moderate, or severe injury. So those things that we use to do that are the Glasgow Coma Scale, which is a 3-part assessment that is given usually as soon as possible. So by EMS at an accident scene, as soon as someone gets to the emergency room, just as soon as possible after the head injury occurs. That assessment involves 3 things. It involves someone's best verbal response. So are people able to speak in a meaningful way? It has to do with people's best visual response. So can they open their eyes on command? Can they direct their gaze? And then it also has to do with motor response. So following simple and more complex motor commands. And that scale starts at 3, not 0, and goes up to 15. And the range of that scale can help us determine head injury severity. Loss of consciousness or changes in consciousness are also ways we can tell if someone has a mild, moderate, or severe injury. PTA, or post-traumatic amnesia, is another important factor we look at. And what PTA is really when people first have injuries, because of all those biochemical changes, because of the disruption about how brain tissue actually works, the brain really isn't making and storing memories the way that it typically will. And so what happens is people will be, let's say, in the hospital, not really able to keep track of their nurses, their diagnosis, what the date is, feeling really fuzzy, not knowing really where they are or why. And that's because the brain is sort of prioritizing neurological recovery instead of some of those more higher order complex thinking skills like memory. And then last but not least, we also look at structural imaging. So if we look at the difference between mild to severe brain injury, we see that with mild brain injury, people are doing well on the Glasgow Coma Scale. You know, they're getting up to 15. They're able to direct their gaze, follow commands, speak to you, tell you their name, where they are. They either don't lose consciousness or don't lose consciousness for very long. They may not have any PTA at all, and typically imaging is normal. Whereas a severe brain injury, if we look at the other side of the spectrum, people are doing really poorly on the GCS. They might be completely unconscious at the scene, and people are usually unconscious for at least a day. Post-traumatic amnesia lasts for at least a week, and then last but not least, we usually have findings, positive imaging findings, when we take a CT or an MRI that really shows us where that damage to the brain is. every severity of head injury has a different recovery expectation. For folks who sustain something like a mild traumatic brain injury, also known as a concussion, we expect them to have full neurological recovery in about 3 months, unless there are pre-morbid factors like things like attention deficit disorder, substance use disorder, other comorbid mental health disorders that can impact their natural neurological recovery or just complicate what it might look like. For people on the moderate to severe time, we expect that recovery happens across about 2 years, but that people might not get back to their pre-injury level of functioning. Because TBI is a new field, we're actually learning that that number is actually far greater. And so there are people who are 5 years out from a severe TBI still experiencing neurological recovery, which is great. The flip side of that is that people who are 5 years out of a severe TBI are also then still experiencing chronic symptoms that can show up and interrupt how they're able to necessarily receive care and how they're able to engage in their environments. So TBI does cause multi-system symptoms because the brain is in, charge of everything that we do. You can really see a range of different things. So you can see somatosensory changes, things like headache or changes to people's ability to use their senses. Headaches do tend to resolve within about the first 3 months after TBI, but for some people, especially people who have a migraine or headache history, that time period can be longer. People also have motor changes, so they can be a little bit slower, they can have paralysis on one side or weakness on one side, they can have slurred speech. People also have a range of cognitive problems. This is typically one of the things that we see as being most debilitating for folks. Gets in the way of relationships, gets in the way of their ability to receive and attend to rehabilitation efforts. It gets in the way of return to work, driving, and so on. The way that cognitive problems occur after a brain injury has to do with both primary and secondary injury characteristics. Primary because there are certain parts of the brain that have certain specific responsibilities when it comes to cognition. For example, the front part of your brain right here, the frontal lobe, is most responsible for executive functioning. So planning, organization, complex attention, decision-making, impulse control. And then secondarily, you can kind of see diffuse changes in the brain if someone has something like a closed head injury, where the interconnectedness of how the brain works can be impacted. And you'll see things like attention problems, slow processing speed. So it stands to reason that if someone has a injury to a certain place, that area in the brain will be preferentially impacted. But because the brain works together, we'll see things like attention, processing speed, problems across the board. And people can also have executive functioning difficulties and memory difficulties regardless of where their injury is. And that's because those are such complex cognitive domains that they rely on a lot of other parts of the brain to work. As an example, for memory to happen, you have to be paying attention. You have to be able to understand what you're trying to learn. You have to be able to organize that in a meaningful way to store it in your memory banks and then be able to take that back out. So memory is not just one process, it's multiple. So usually some of those higher order functions are also impacted. Psychologically, you can see a range of things from depression and anxiety to acute stress, which may develop into PTSD based on the nature of injury. So especially if someone has, had a really scary car accident, or maybe been a victim of gun violence or another assault, that can really also complicate what their TBI recovery is going to look like. Most people also tend to struggle with adjustment disorder to some degree following TBI. And then last but not least, you can see a cascade of behavioral symptoms and changes as well. So people may experience some changes to their personality. They can have anosognosia, or what we call reduced awareness. They can have, substance use challenges. They can have sleep disturbances, sexual dysfunction, decreased social cues, where they're really not able to understand facial expressions or sarcasm, and communicate socially the way that they used to. And so that is a sort of snapshot of the array of things that a single patient can experience following a brain injury. So it's pretty vast, and it can look very, very different for different people. Okay. So let's transition to just a refresher on substance use disorder. So substance use disorder is a complex psychiatric disorder. It is in the DSM-5 labeled as being uncontrolled or persistent use of any substance, despite that use resulting in negative consequences just repeatedly in someone's life. It is also known as an addiction. We don't really use that term anymore because it doesn't fully captivate the range of things people struggle with SUDs. The cause of SUDs is unknown, but typically what we're seeing is that genetics are playing a role. Any exposure to adverse childhood experiences, early exposure to any particular substance like alcohol, nicotine, marijuana, and then any comorbid mental health condition can increase the risk of the development of SUDs. And of course, traumatic brain injury, because of that cascade of symptoms, the cognitive, psychological, and behavioral challenges, people can also be more at risk for the development of SUDs after a brain injury. So some of the key features that we see in SUDs has to do with intoxication, really that feeling when you are first exposed to a substance. So that sort of euphoric feeling or that state of relaxation. Tolerance, which happens when people are using a substance repeatedly. They tend to need more over time to keep getting that intoxicated feeling. And then withdrawal, which is a state where the body is trying to rid itself of the substance, but the brain sort of now becoming addicted to the feeling of that substance is sort of yearning for more. And withdrawal tends to go back to the beginning. So withdrawal makes people really want to become intoxicated again and use that substance again. So there are 4 categories now of symptoms that we use for the diagnosis of SUDs. Impaired control, so not being able to control use of a substance despite those negative consequences. Social problems, so when you are using a substance and it's impacting your relationships, your ability to work, your ability to go to school, but you still use despite those consequences. Dangerous use, so using a substance even though you know that it's impacting your health, even though you can tell that you've had cognitive challenges as a result of that use. And then last but not least, those drug effects. So there's going to be the things like intoxication, tolerance, and withdrawal that we just went over. So just like traumatic brain injury, substance use disorder is also pretty multi-layered. All right. There are a number of complications associated with SUDs that we also don't talk about that often. So one of the most important things is that people who use substances are at very high risk for cardiovascular health problems. Many have things like heart attack and stroke as a complication of their substance use. They can be more at risk for the development of diabetes, as well as infections for things like hepatitis. People who use SUDs are also at increased risk for the development of mental health diagnoses, so things like depression and anxiety. And people will also struggle with cognitive problems that really distort their thinking and change their behaviors. As I mentioned before, when we're talking about secondary injury mechanisms in brain injury, when we use substances, it actually changes our brain at the chemical and neurotransmitter level, changing the way the body responds to and the brain responds to impulse control, the idea of reward and punishment, which is really how we learn, how the brain learns. And most substances can actually change cognitive profiles too, and I'll show you that in a little bit. What we're seeing now with some of the newer technology and fMRI studies is that things like positive and negative reinforcement, things like decision-making, cognitive flexibility, and how we're able to control our impulses are heavily impacted in substance use disorder. Okay. So I looked at a bunch of different resources that are patient-facing, so things like SAMHSA, things like the CDC, to look at what the most used substances are. And the most used substances are alcohol, which is #1 in the United States, cannabis, cocaine, opioids, methamphetamine, and tobacco. So those are some of the substances that people are using most often. And as I mentioned before, when we think about substances and its impact on the brain, understanding that it can change things like impulse control, decision-making, how we learn, it also stands to reason that can affect other cognitive domains in the brain as well, and it does. So we have a lot of studies that show people with certain substance use disorders who are, going under neurocognitive testing and then compared to a population that is not using substances, and we can kind of see the difference, what the long-term cognitive impact of substance use is on brain functioning. So on your screen here, you'll see that things like persistent alcohol use can cause variability in cognitive domains. So things like sometimes your memory working well, sometimes your processing speed working well. So the brain's really kind of going in and out when it's sitting down with one single task. It can affect attention, processing speed, executive functioning, memory, emotional processes, and really increase risk for things like depression. And it can also reduce people's social cognition, or that ability to sort of socialize, connect, understand someone else, and vice versa. Cannabis use affecting learning, memory, executive functioning, attention, motor skills, language, processing speed, and also disordering sleep for individuals who are using cannabis. Methamphetamine use also causes quite a bit of challenges for the brain after long-term use, primarily attention and executive functioning, particularly in impulsivity and reward processing, can affect how somebody learns, remembers, and again, that social cognition piece. Cocaine use can impact learning, visual memory, executive functioning, and change the way people respond to pain, making them more sensitive to pain, and can also increase mood lability or mood swings. And then last but not least, opioids. They also create a lot of changes in the brain, which a lot of people actually don't realize. It can change how people respond to rewards, also really affecting that pain sensitivity, decreasing people's attention, which underlies so many other cognitive processes, increased risk for generalized anxiety disorder, and then also disordered sleep, which then in turn can cause a whole cascade of other health and psychological problems. So if we kind of put all of that together, what we're really seeing is that traumatic brain injury and substance use disorder has a, pretty like vicious cycle type relationship, right? If you have a traumatic brain injury, it can cause changes to the way that your brain functions and understands in a way that can cause you to be at risk for the development of a substance use disorder. And if you have a substance use disorder, it can put you at risk for the development of something like a TBI. If you have both a substance use disorder and a TBI, there can be other issues. For example, substance use disorders preferentially decrease how much neurological recovery the brain has following something like a traumatic brain injury. Both are going to increase other health problems. Both are going to increase the risk of the development of something like a mental health disorder like depression or anxiety. And both are going to change cognitive abilities, which lead people again to using more substances and then potentially having another brain injury. We know that at least a quarter of the people who are seen in the emergency rooms in trauma centers for traumatic brain injury are already diagnosed and confirmed substance use disorder. But up to 50% is probably the more accurate number of folks who have both. So I just want to kind of talk about this. We already touched on it, but just to kind of double down on it, TBI and substance use really have a lot of similar symptoms. And because of that, there's a lot of symptom overlap, but more importantly, exacerbations of symptoms that can really get in people's way. So both have cognitive problems, right? Both have changes to the way that emotions work. With brain injury, people are less able to regulate their emotions. And with substance use, people have increased emotions. So if you have both, you both have increased emotions and difficulty regulating those, working through them. People have behavioral changes in brain injury, and with substance use, reduced locus of control, less of a feeling that they can fix things and control things in their lives. So that can also be a pretty hefty combo. With TBI, you're seeing anosognosia, and with substance use, you're seeing increased health problems. So you have this reduced awareness, and at the same time, the susceptibility to an increase of all of the different health and psychological difficulties that you're struggling with. And then both, on top of all of that, are impacting relationships. And we know that things like social support and connections can be vital, super vital, to people when they are recovering from any kind of injury, especially something like a TBI or substance use disorder, when you're really needing that additional support. So all of these exacerbations can really create a very complex picture, not just for the patient, but for their loved ones, and then for their clinicians who are working with them to abstain, to recover from the brain injury, and to try to do that in a way that balances the difficulties with both. So it can be a really tough picture. All right, so I want to transition into kind of looking at what group interventions in therapy might look like in this population, or really any population. So with group settings, when you're kind of working with people in a group setting, there are some key factors that can be super helpful in creating a therapeutic space that fosters healing and the development of education and strategies to help compensate for things like cognitive problems and develop skills for emotional distress. So my favorite group therapist ever, I'm still pretty old school, is Irving Yalom, the godfather of group therapy. I love him. So shout out to Dr. Yalom, wherever he is. He had this sort of 11 things that he said, this is what you need if you're ever treating anyone in any group setting. And those are on your screen, and I added two to his list. Heavy-handed, I know, but what we see is that groups need really to be focused on this idea of hope, so that the people in the group have hope that things are going to get better. Also, universality. So if you are doing something like a group for TBI and substance use, that idea that group members are now with other people that are struggling with the same things that they are, that can be really healing in and of itself. Information and education needs to be a core component if you're ever running a group, because helping people understand their symptoms, arming them with that knowledge, can create a lot of autonomy, which can help put people back in that driver's seat and reduce that issue with locus of control, so that people can feel like, I can get better if I want to. Altruism, so really everyone in the group not wanting only to help themselves, but to help one another. And then groups do a really nice job. I'm going to hit on a couple of points here at one, for creating corrective relationships through learning how to socialize again and how to receive support from their peers, from other group members, right? This is so important because if you remember, with traumatic brain injury and with SUDs, we're seeing a lot of reduction in social cognition. So if you're ever doing treatment with TBI, and if you already are running a group or considering running a group, it can be a great way to improve social cognition, because you're really launching people into a social setting. People need to have what we call group cohesiveness. So this development of trust that happens in a group, where a group really starts developing a culture of its own. It becomes a little family unit. And the way that that happens is through things like disclosure and this recognition of other factors that people might be kind of dealing with. Yalom talks about existential factors, but I think for our purposes, I'll lean into things like cultural factors. You know, what are people's unique identities that they're coming into the group with? What are people's home lives like? You know, what languages do they speak? All of those different things can impact their symptoms and how they present very differently. And then last but not least, groups really need to be present-centered. You know, of course, there are things like therapeutic process groups where people are doing a lot of emotional processing, but for a traumatic brain injury plus SUDS group, any kind of intervention like that, while processing is great, we also want to make sure that we are making space for the idea that people in that moment have difficulties and symptoms that are tough. And we want to promote healing for the brain and abstinence. And how to do that is to move forward and really focus on problems and use that information and education to help people understand how to, you know, compensate for those difficulties and learn different skills so that they can move forward in a meaningful way. Okay. So in group settings, we really want to promote engagement, and engagement in group settings can be pretty difficult sometimes to gauge unless you are doing something like making sure that if you're running a group for TBI plus SUDS, that you have a group assignment, you're looking at readiness. And the best way to do that is through assessments. Really assessing if the person that you're wanting to put in a group, if you think that would be helpful for them, if they're ready to be in a group. And so there are a number of different assessments that you can use. And you can also use things just like a good clinical interview. The other thing is to review expectations with people and see if they are willing to, you know, be in a group, disclose in a group, keep what other people say private, if they're ready for that. You know, most people will tell you if they're able to. You also want to encourage cohesion, really early on in a group. So one of the biggest things that I recommend are things like icebreakers, things like breakout groups. So maybe you have a group of 6 or 7 people that you're working with. Maybe one day you're working on, you know, memory strategies. Maybe break everybody out into groups of 2 or 3 so that they can work with an exercise you give them in smaller groups so they can develop those relationships, develop that trust. And then also taking time not just to focus on processing and education, but really making sure whether you use breakout groups or you stay in a large group, that people are practicing the things that you're teaching them. You also want to, from day one, really promote this opportunity for people to give not only you as a facilitator, but one another feedback and reflection by modeling that early on in the group phase. And then biggest thing here is to address issues immediately. We think back again to those symptoms of SUDS and TBI, we can see that learning is so preferentially impacted. And people learn pretty quickly. And so you want to make sure that if someone does something that's inappropriate or that's not going to be helpful to the group, that you mention that right away. And then last but not least, just acknowledging that the group that you're going to be working with is going to have cognitive and psychological difficulties, and that we need to make accommodations in space for that so that they can really fully benefit from any programming. And even if you're not running a group, I noticed some people in the comments, I wasn't sure if everybody was running a group based on that. But if you're not running a group, some of these things are important too, right? So if you're working in a large setting where people with brain injury and substance use disorder are interacting with one another, doing things like icebreakers, giving people the opportunity to learn about one another in a way that they feel safe can really help improve cohesion and trust as well, which can go a long way for mood and management of difficult behavior. Okay. So some general accommodations that you're going to want to consider in any kind of treatment with someone with a brain injury and comorbid SUDS have to do with just making space for the fact that there isn't that sort of normal cognitive process. So you want to make sure you're doing things like you're going slower. You're giving people additional time to respond. You're using simple language, providing a lot of repetition, that you are making available compensatory strategies for memory, like giving someone a note that has an overview of what your session involved at the end of that session. Even if you take 5 minutes and work on that note together, you don't have to pre-prep it yourself. You can actually engage the person you're working with and have them do that with you. That's a great cognitive exercise. And just making sure that you're doubling down on the fact that there are expectations and making sure that they're delivered in a way that's understandable to your patient. And then you want to make sure you're building self-awareness, making sure that people are aware of not just their difficulties, those, interfering symptoms, but also their strengths. And you want to do all of this under the lens of trauma-informed care, really building respect, being respectful, building a sense of safety, and then harnessing that sense of hope. Always asking permission first, no matter what you're doing. Okay, so I want to go through some kind of curated vignettes that I put together that have to do with sort of group settings where a patient with a comorbid TBI and substance use disorder may be presenting with certain symptoms that can get in the way of the therapeutic process, and how you might be able to accommodate your work so that that problem can be minimized and the person can fully benefit from any treatment. So I want to start with anosognosia because I think this is a pretty big thing and something that we don't necessarily talk about as often. So anosognosia is a neurological deficit. It is associated with traumatic brain injury, and it is basically a super fancy word for reduced awareness. How anosognosia happens most often is because of primary injury, so a blow to the head in the frontal or parietal lobes on the right side of the brain. So right frontal parietal injury, if you see that or read that, someone may be at a risk for anosognosia. What that means is that you may have some behavior like this. So here we have a scenario where Mark, a 31-year-old white male, is attending a group intervention. He is diagnosed with alcohol use disorder and recently sustained a moderate TBI. So what Mark does is in the group, he's always like, I don't really have a brain injury. I don't really believe that. Like, I've had no cognitive problems. My day-to-day life is pretty normal. And he kind of downplays the strategies that you're giving people, downplays discussions related to brain injury, because he just really is not able to kind of see some of the symptoms that he's experiencing. So to help someone like Mark and help the people that he's interacting with in any kind of group setting, here are some strategies that you can kind of consider. So first one is making sure you are providing education, right? Education about brain injury, education about the possibility of reduced awareness, and you're doing that with permission. So something like, hey, I know you feel like, you really don't have a brain injury and you're not seeing symptoms, but would you mind if I just shared a little bit more about brain injury with you so that if anything comes up, you'd be able to notice it? So really kind of asking permission instead of just giving information, because sometimes there can be this like, whoa, right? Because it's like, I don't have that. But when you're asking, you're sort of really inviting a collaboration, which can help a lot more. You also want to focus on consequences. Someone has reduced awareness of their abilities. You might say, okay, so you're not seeing problems. That's fine. But right now you've been put in this treatment group, right? And so since you're in this treatment group, let's focus on what this group can do for you moving forward. You also want to make observations. So you want to point out how people are doing, good and bad. And you want to do things like self-awareness exercises. There are some great self-awareness exercises in some of my favorite, TBI workbooks, and I'll share that information with you guys at the end, that you can use in group settings and even one-on-one to help boost and improve people's awareness. You want to encourage peer support within the group, letting them work with someone else who's had a brain injury, someone else who's maybe had reduced awareness as well. And then you want to use motivational interviewing skills and creating person-centered goals to move someone toward this idea of change when, just kind of respecting their readiness for that change. Another thing that will come up when you're working with folks who have comorbid TBI and SUDs is this reduced attentional control. Not really a behavioral issue, an attention problem isn't. If you think about it, it's a cognitive problem. But if you've ever been around someone who has a lot of attention changes after a TBI or because of SUDs, you can see that it can affect behavior quite a bit. So you'll see things like inattention, difficulty paying attention for a long time, becoming easily distracted, and really having maybe slower processing speed as well. And so an example of this, what it could look like is, let's say Louisa, 22-year-old Black female, she's attending a group and she had a severe TBI and has comorbid substance use disorder, both alcohol and cannabis. So Louisa is in group, she's easily distracted. She's talking to her neighbor while other people are speaking. And so the facilitator will go to her and say, hey, Louisa, you can't do that. If I'm speaking, you're quiet. If other people are speaking, you're quiet. Wait your turn, right? So they have these back-on-back one-on-ones, and the behavior just continues. It's really hard for her to pay attention. So what do we do, right? Well, there are a couple of different things that you can do. The first thing, and this is the thing that I would always first recommend, which can be great for any group or any setting where you're working with folks who have brain injury, is limiting the amount of distractions. Ways you can do this is to ask the patients you're working with, or if you are doing group therapy, ask the group for help. What is distracting for you guys in this environment? Like if we have to think about distractions in this room right now, what comes up? And then seeing if you can reduce those. Also, if you are in group, acknowledge any change in the environment. If someone slams the door down the hall and you're working with someone with a brain injury or a substance use disorder that has attention problems, guarantee that's distracting them. So note it. Hey, that was crazy. Did you hear that door just slam like that? That got me off track. Let's take a second, reset, and get back on track. You can also really focusing on keeping your language simple to make sure people are able to more easily follow. Sometimes when things get a little bit complex, it's almost easier for the brain to be like, I'm not going to do that right now, and then kind of wonder. So keeping things simple is super helpful. You also want to do something like creating an interruption catchphrase. So maybe you say something like red herring, and the group gets used to you saying red herring, and that means, okay, you guys aren't focused. I need you to focus back on me. So similar to limiting distractions, you want to set up your environment for success. So ask the group to help, review group rules at every session, review them with the entire group, not just one-on-one. That kind of social learning, that imitative behavior helps a lot more than when you're just meeting with someone one-on-one for a lot of interrupting or difficult behaviors. One thing that you can consider is having a different person go over the rules each week. That can be super helpful. You want to bookend your sessions. And what I mean by that is start by saying what you're going to do and end by saying what you just did. Those are really nice anchors. And you can also provide cues. So like if you are going to mention something important, say, hey, I'm going to say something important right now, because it really will jog people's memories so that they're able to refocus on you. Follow an agenda. That's super helpful. And then consider multimodal activities. So like I mentioned earlier, doing things like breakout groups within a small group, watching a video together, listening to a song, doing a mindfulness exercise. If you're giving the brain different types of information, if it's being presented in different ways, not just through speech, that can really keep the brain alert as well. Okay. Fatigue. So fatigue is a big issue that people struggle with after a brain injury as a result of neurological recovery, and can also be super difficult for folks after substance use disorder is diagnosed and when they're first in treatment, especially in initial days when you're first sort of in those initial stages of abstinence. Remember, fatigue can present in a lot of different ways: physical, mental, emotional, and sometimes people can have all three at once. So let's look at a scenario. So we have Sam. He is a 55-year-old white male diagnosed with an opioid use disorder. And he has also suffered repeat remote traumatic brain injuries. So a couple of brain injuries back in the day. And what happens with Sam is he's kind of gazing off in group. He's gazing off while you're talking to him. He's not really clearly paying attention. And a couple of times he falls asleep and it needs to be woken up, right? And other people are complaining. They're like, hey, he's rude. He's not paying attention when everyone else is kind of processing together. Like, they don't like that. You need to do something about Sam, okay? So what can you do about a brain injury plus SUDS patient who is presenting with this kind of fatigue? The first thing you can do is ask your group for feedback, or ask the individual that you're working with for feedback, right? What is the length of time, the length of this appointment feel like for you? You know, for us, 45 minutes, 60 minutes, 90 minutes might feel like a short period of time, but that can be very different with someone who survived a brain injury. See about the time of the appointment. Is it too early in the morning, too late in the afternoon? And are there things happening that is overstimulating this person? That can happen because of fatigue. It can happen because of those attentional control issues, but overstimulation is a real issue. And it can make people at risk for agitation, mood lability, more fatigue, more memory problems. So ask for feedback. I know sometimes we don't necessarily have as much flex if we are running a group, or if you are working one-on-one people, you only have a certain amount of time in your day and caseload. But if there is opportunity for flexibility, take it as much as possible. And then incorporate flexible problem solving for a patient like Sam. You know, ask about other healthy behaviors. What's your sleep like? What's your diet like? What's your how much physical activity are you getting a day? And how can you incorporate healthy behaviors into all of your therapy efforts with your patients? And then definitely incorporating what we call fatigue management in rehab. And so fatigue management has to do with this idea that we don't only want to increase rest when someone is fatigued, but we want to balance that rest with energy like coming in, right? So what gives you mental energy? What gives you emotional energy? What gives you physical energy? You need to balance that with rest in order to really improve fatigue long term. Of course, we want to be really gentle. And if you need to, this is probably a time when I would work one-on-one with someone like Sam and say, hey, let's talk about your sleep. You know, do you have trouble falling asleep, staying asleep? Are you waking up too early? Maybe doing a screening, because there could be a medical problem going on that he may need some help with. All right, so let's look at impulsivity. So this can be a pretty big issue. So impulsivity, really common with brain injury and substance abuse disorder, and can look like a lot of different things. Can look like impatience, restlessness, decreased frustration tolerance, right? So in a group, let's imagine we have Adams. He's a 34-year-old Latino male. He's pretty impulsive in group. He's had a long history of cannabis use, and he sustained a severe traumatic brain injury about 2 years ago. So Adams tends to direct attention away from the group. Facilitator, he'll tell random jokes. He'll be flirting with people who maybe don't want him to be flirting with them. And he's really just consistently restless, moving around in his chair, cannot sit still, right? So how do we help Adams? So some of the accommodations you can make to your treatment here is when you see impulsive behavior happening, especially like, someone laughing and telling jokes, stop everyone. And you don't necessarily have to point it out. You can. Making directive observations is really important. Hey, I can see that you're talking to this other person. I'm going to wait for you to stop so we can get back to our agenda. redirecting people to the agenda. That's perfectly appropriate. But sometimes it's also nice to encourage the entire group to take a pause. Like, okay, I'm seeing some impulsive behaviors here. I'm seeing you guys joking around. Let's all take a moment, and you do a grounding exercise. Maybe do some deep breathing. Get everyone back on track. Refresh that mental palette. Then the person who is struggling with the impulsivity, you can also help them to self-monitor through exercises. You can teach this to the whole group as well. You can help them learn what their triggers are, help them learn to label their emotions so that if they are feeling tense or anxious or overwhelmed, they can label that and recognize that that can be a precursor to some of those impulsive behaviors, which means that they can potentially learn eventually to redirect themselves. You also want them to really practice self-compassion, and you can help model that quite a bit in group. You also want the whole group to make observations too. If impulsive behavior keeps happening, invite the group to note it, right? Hey, if you guys see, impulsivity, point it out, and let's help this person. Let's find out what their trigger was. Let's help them label their emotion. Let's practice self-compassion together. And then when any of those things fail, the thing that I always fall back on that is so helpful are those core DVT skills. So if someone is struggling with impulsive behavior, thinking about things like the stop technique, the cope ahead technique, there are tons of wonderful DVT skills and strategies that can be useful. So sometimes in group settings with folks who are diagnosed with TBI and comorbid SUDs, we'll also see executive dysfunction that can present like perseveration or getting stuck on a topic, and tangentiality, which is sort of when there's a topic at hand and someone's trying to answer a question, but they're kind of going all the way around and might not make it back to the point. That can happen pretty commonly with TBI and SUDs and can happen to varying degrees. So when you're trying to treat someone, whether it be one-on-one or in a group, it can really get in the way. So let's look at this scenario. So Jenny is a 30-year-old biracial woman, and she had a recent brain injury. She has a long-standing alcohol use disorder, and she's very active in group. But she frequently gets stuck on topic and will keep going back to the same topic in group, no matter what the agenda is. And when you do try to redirect her back to the topic at hand, she can sometimes become tangential. She'll struggle to answer direct questions and kind of really have to talk around the issue, being pulled back to that thing that she just really, really, really wants to talk about. So how do we accommodate for the symptoms of tangentiality and perseveration in group? So again, just like with impulsivity, making direct observations that you can see that that's happening is helpful. It's also good to ask for more information. Sometimes people want to slow people down, get them to completely stop, but it's sometimes good to really kind of take it apart one day and say, okay, I can see you keep returning to this. Let me ask you some questions about it. That can sometimes really help flush out the system and get whatever's off someone's chest resolved. You also want to sometimes, acknowledge, right? Hey, I see that you're really, really wanting to talk about this, but I want us to get back to the agenda and then get back to the point and literally ask the person, take a minute to reset, and we'll come back to that. You can also redirect, but instead of with talk, like the facilitator did in the scenario, you can redirect with an activity. Sometimes changing everything up, and instead of continuing to talk about a specific topic, but saying, hey, let's work on this topic together now, right? And then, do something like breakout groups can really help reset the whole group. You also want to remind people of their goals. So sometimes people will be talking about something that isn't really relevant to their goals. And you can ask, hey, you have this goal. You have a goal to really focus on your abstinence when you get home and not let your memory problems get in the way. Is this topic going to help you with that goal today? Right? If it is, let's talk about it. But if it's not, let's move on. You also want to create a stuck signal, right? So you can say something like, jellyfish when people get stuck, and that be the signal you teach group to say, hey, I can tell you're stuck. You reset. We're going to move on, and we'll talk about this more later if you need to. And then last but not least, sometimes it's important to really investigate concerns. Sometimes perseveration is just perseveration and people getting stuck because of executive dysfunction. But other times perseveration is actually someone's really concerned about something and no one's listening to them. So investigating what might be going on can be really helpful. So let's look together at inappropriate social behaviors. So inappropriate social behaviors kind of sounds like what it is. Because of that reduced social cognition in TBI and SUDs, a lot of people struggle with, just not necessarily behaving the way socially that you might expect. So here we have Liam. He is a 19-year-old white male. He has a history of a severe traumatic brain injury and recent methamphetamine use, and he is joining your group. He just does not respond well to social cues. He doesn't seem to necessarily understand facial expressions, and he can sometimes laugh inappropriately when other people are sharing sad and really moving information, and it's making the rest of the group uncomfortable and frustrated. So what can you do about Liam, right? How can we help Liam help the group? And so one of the things that is really important here is this idea of relearning. And this makes groups so awesome for people who are struggling with social cognition, even though it's tough work for the facilitator, because you're going to have to help manage the resulting difficult symptoms, difficult interactions, right? But here is a nice opportunity to sort of relearn what is expected in society. So one thing you can do is teach your group to take a bird's eye view, right? So you can give them a scenario like, hey, okay, we have a person that had a brain injury. They're super forgetful. They go to the grocery store. They forgot their list at home. They become so upset. They also have a substance abuse issue. They go into the grocery store. They buy a bottle of wine. They drink it in the parking lot. And you can say, what are the problems, right? Most people are just going to talk about that person, that forgot their list at home, became upset, and went in to buy a bottle of wine. But what if we zoom out? What are the other things that could be at risk? Well, if this person's driving, they're putting other people at risk. Well, what about this person's care team? Their family that are supporting them? What is the bigger picture? What about long-term health impacts, right? So teaching the group to take a bird's eye view can be really helpful in improving pro-social behaviors. We also want to encourage, like I mentioned in the beginning, reflection of one another that is respectful. And then as much as is possible, reteach empathy. When people can't be sympathetic or empathetic to one another, just making sure we're always creating a safe space that is respectful for one another. You can also point out to people like, hey, you seem to laugh right now, or smile, and I'm just checking in. Were you thinking about something? Because kind of what we were talking about was a little sad, a little down. Remember, it can be challenging for people to do simple things like label emotions after something like a brain injury because they're having difficulty recognizing and regulating their emotions as it is. You always want to summarize what you've heard so that you can make other people aware of what was just said, because sometimes people weren't listening. And then really use concrete examples, avoid things like sarcasm, avoid things like analogies so that people can really understand basically what's going on and not have to sort of mentally flex to understand some of those more nuanced social interactions. So a lot of times you're going to see emotional dysregulation. And with emotional dysregulation, you can really just see mood lability, mood swings. This can happen often in TBI and actually really often in SUDs as well, as people sort of have to start working on developing those skills again of managing their emotions instead of self-medicating. And so with this, we have an example here of Shannon. She's a 8-year-old white female. She had a recent TBI. She fell after drinking and also has a history of alcohol use disorder. Also a very active member of the group. And Shannon, unfortunately, will sometimes become so upset when discussing parts of her own history. She'll become tearful, she'll start shaking, and she'll just be really inconsolable for long periods, pulling attention away from everybody else, the task at hand, the agenda, because of how distressed she is. So how can we help a person like Shannon, and how can we keep that treatment on track? So the first thing here, we've used this example again in the a little bit earlier, is engaging in that group centering with an emphasis on moving forward. Okay, so we have someone who's really upset right now. Let's take a moment for the whole group to just reset together, decrease some of that emotional content so we can clear our heads and move forward with our agenda. So be intentional, say that you're wanting to move forward, and then engage in an activity like that that doesn't necessarily hold just one person out. You can also focus on teaching and integrating simple skills that are easy to incorporate to help people manage their emotions, name their emotions, and then help clarify needs in group when someone does become really upset. Hey, I can tell you're really upset. What can we do to help you right now? Right? What can we do to help you right now? Because we do need to move on. We only have 20 minutes to go. What can we do? Right? And then really kind of assessing for things like the presence of other mood disorders to make sure that this person is getting all the treatment that they need. So agitation is a big deal after traumatic brain injury, especially in the early days. It can also be a big deal again with substance use disorder as people sort of stop relying on substances and have to rely on their own coping skills. So here we see aggression that can be verbal or physical. We can see restlessness, disinhibited behavior, maybe saying things that you shouldn't say out loud, that people, just kind of say whatever's in their head. And then again, some of those bigger mood swings. And so with agitation, we have another scenario. Liam, I think I used Liam twice. We have two Liams. Okay, so Liam, 29 years old this time, Latino male assigned to group. He has a history of multiple TBIs as well, and an opioid use disorder. So he's become actually verbally aggressive in group. He's cursed, he's yelled, and he's showing signs of physical aggression. So you're kind of worried that he might physically react. He's tensing his neck, balling up his fists, tensing his hands. So how can we help Liam? So some of the accommodations here really have to do with in the moment verbal de-escalation techniques. This is time and time again the most useful thing to do that's promoted in literature and in the research. I can do a whole 90-minute talk just on de-escalations. I'm just going to hit the highlights. So with verbal de-escalation, you really want to reduce your volume, slow your pace, and have a soothing tone when you're speaking to people. You want to tell them what you're seeing. Hey, I can see that you're upset right now, and I want to be helpful. Is there anything that I can do? Would you be willing to talk to me about this right now? You want to ask permission. You want to go slow. You want to really be non-threatening in the way that you're handling stuff. You don't want to step up out of your chair and go to that person and corral them into a corner. That's never going to be a good idea. You want to give them space, and you want to ask for a lot of permission. You want to ask open-ended questions so that you can get more information from them, and you want to validate those feelings. You don't necessarily want to validate their complaints because they might not be factual because someone's so upset, but you do want to validate how they're feeling in that moment, right? And you really want to talk to them about moving them out of that state. Like, I really am going to need us to move forward. Don't tell someone to calm down. That's a trigger, I think, for everybody on the planet when they get told to calm down, right? But you do want to say something like, we really need to get back to group. Do you need something? Would you like to get back to group as well? How can we help get you there? And so you want to really ask a lot of permission, be very forthcoming, be very gentle. Same thing here as with attentional problems. You want to reduce environmental stimuli. You want to limit distraction. You really don't want 17 people talking to one agitated person at one time. You just want to have one person talking to an agitated person at one time. You want to model that calm, and you want to know triggers, right? In the future, what is something that happens before this person gets super upset, especially if it's something that you can pinpoint. And if it's not, after the fact, having a conversation with Liam and saying, hey, you got super upset today. What was happening this morning before I saw you? Like, let's go through it, because I feel like there's something that's triggering you, right? And kind of really talking through that with someone. And you want to encourage group redirection, have everyone do a grounding exercise, and have everyone help relearn appropriate social behaviors together, right? Remind people that they are in control of their own behaviors, but at the same time, remind yourself that emotional regulation in the case of folks who are diagnosed with TBI and substance use disorder is a privilege. Like, we're privileged today to be able to come to work and really regulate how we feel. These people who are diagnosed with comorbid TBI and SUDs, they don't have that privilege. Their emotions are a jumble because their brain is not necessarily currently equipped to deal with the intensity of them, right? And so how can we help them relearn that they're in control? How can we create signals for them to let them know, hey, a trigger is happening? How can we create education opportunities for coping skills and retraining? And then when they are calm and relaxed again, ask them for feedback. Like, hey, you know, we spoke when you were super upset earlier. How did I do? Do you feel like I handled that well? Is there a way you'd prefer someone to handle that in the future? You know, so that you can kind of help people. A lot of times people will tell me, because at least once a day I have a very agitated patient. People are like, Dr. Full, we need you to come up. This person's agitated. And that's kind of my like go-to calling. And, you know, later on, I'll ask people and they'll say, I just want someone to sit with me, but give me space, right? A lot of people just need a few minutes to kind of come back down, and that's okay. And so you can really be more helpful if you ask for feedback about how you deal with these things in the, after the moment as well. Okay, so I always think it's important to talk about when these things that someone is telling you, hey, you should try, don't work, because I'm not necessarily going to be there for you to consult with in the moment. So if you try some of these things and they don't work, here are some ideas that can kind of be helpful for you as well. So if you are having, you know, very disruptive behaviors, whether it be in a group setting, an individual setting, and nothing you're doing is working, a big thing to consider is repeat cognitive testing. Maybe there's something that was missed the first time around. Maybe someone hasn't had cognitive testing. And if you have that cognitive testing, you can really see where people's symptoms are, and you can make better accommodations once you have that information. Same idea with psychological testing. They could be something that's missed, maybe something like really severe PTSD, right? And so having that information can also help you adjust your treatment modalities. If you are doing group therapy and it's not working well, you can also increase one-on-one therapies with the person who is struggling, whether that be with you or with someone else, depending on how your institution works. It can be really, really helpful for them to have more opportunities to work with a different clinician in a one-on-one setting. And then you also want to increase your rehabilitation modeling in your groups and in your treatment and all of your communication with people. Just remembering again that everybody with comorbid TBI and SUDs is going to have some variety of cognitive change, and they're going to need some compensatory strategies for that. You can also encourage people to work one-on-one with a group member if that's allowed at your institution. I have a grant-funded traumatic brain injury group here in my community, and one of the things that we've launched is TBI peer supports. So really modeling from that substance use disorder model, you know, the 12-step program and things like that, that has a lot of good research behind it. You know, people have these mentors, these supports that they can call and contact. And so we're trying to do the same thing with traumatic brain injury. It's been launched in a couple of places, and it's very, very effective because, again, you have that universality. You have someone who's been through it, who is still going through it. So there's a lot of acknowledgement, there's a lot of connection, and there's a lot of just straight out the gate buy-in that this person is going to be helpful. People don't necessarily have the same buy-in when they're, you know, meeting a new therapist or clinician or doctor, because maybe they haven't liked some of their doctors or therapists in the past, right? That's not going to happen with peer support. You can also use things like the use of props in groups. You can have something like a talking wand, right? You can't talk unless you have the wand. That can sometimes help as well. People don't love it, but if you have a really disruptive group, it tends to work. And then last but not least, you want to kind of focus in on identification of the problem. So there's this quote by Einstein where he said, if you give me 1 hour to solve all the world's problems, I'm going to take 59 minutes to figure out what the problem is, and I'll only need 1 minute for the solution. And the idea behind that is that a lot of times we're applying solutions to something that isn't the problem. And so the problem is going to continue. So an example here would be, let's say someone's in group and they're really impulsive and they're interrupting all the time, right? So you try all the things that I recommended to help decrease, impulsive behaviors in a group, decrease that distraction that comes along with interruption, but the problem doesn't go away. Well, maybe the reason that person is interrupting is because they have really bad memory problems and they keep forgetting. They keep forgetting what you're talking about, or they want to interrupt super quickly and say what they're thinking because they're worried they're going to forget it. Maybe their processing speed is really slow and they are kind of interrupting because they've just now processed what you said a few minutes ago. And they also don't want to forget. They want to kind of blurt it out so that it's out there and they get their chance to share. If you keep just applying solutions to one portion of what that problem sort of presents at, sort of like an offshoot of that problem, like interruption, you keep applying solutions to just that problem is going to continue, because the real problem, the thing that needs the solution, is that memory difficulty, is that, that slowed processing speed. So make sure that you are applying solutions to the problem. Okay. Let's talk for a few minutes. I'm kind of watching the time as well. I know we need to have some time for questions. So I want to mention, and I just want to acknowledge that if you're working with survivors of traumatic brain injury and substance use disorder, you're doing incredibly meaningful work, incredibly rewarding work. It's a very inspiring population to work with, but it is also a very challenging population to work with because of the myriad of symptoms that people have and how those symptoms can exacerbate one another. And so we're really sometimes in very high pressure situations. We have people, everyone has a TBI, right? Everyone has a substance use disorder, but because of people's individualities, our unique identities, the variable substance people can use, how different injuries can look different, you can see very nuanced and individual presentations. And so while everyone might have a memory problem, everyone might have emotional ability that can look 100 different ways, right? So you have to be always flexible, always counseling, always monitoring, always observing, right? And that can be really, really tricky as well. And so what ends up happening is clinicians can become really fatigued. We can have emotional and physical and mental fatigue. We can have a lot of exposure to secondary trauma that we don't necessarily go to a therapist ourselves and work through, right? All of these things can lead to burnout. And a lot of times with clinicians, we power through burnout. We really feel so committed to our patients. We just power through it. And that can also mean that we have increased reactivity too. We can be more easily frustrated by an interruption because we're sick of it. We've had 79 interruptions in the past hour, and it can be hard for us to manage, right? So some of the things that we can do to kind of help ourselves, and I wish that we all got to do like burnout workshops once a year so that we can kind of help one another better as well. But here's a sort of a very brief overview. Burnout is work-related stress. That's what it is. It's work-related stress that results in a lot of fatigue and exhaustion. It can cause things like, having difficulty sleeping, having a shorter temper, feeling more depressed, and it can really reduce how much we feel like we're doing at work, and reduce our own sense of personal identity as well. So it can have a lot of negative consequences. And so what are some things that we can kind of do to reduce the impact of burnout and really make sure we are well in the context of providing wellness to so many other people? So one of my favorite things is consultation. I think it's so nice to be able to consult with people when we are struggling at work, or when we have a patient that is really, giving us a run for our money. But I also think it's important for us to consult when things are going well. So hear me out, right? We usually consult when there is a challenge, when we are confused about a patient presentation and we're looking for ideas. But it's equally as important to consult with people when things are going well. Hey, I have this great patient. We did this stuff. Things are going so well. I have this group. We're working on these skills. Everyone just really took them in today. Things are going super well, and still get feedback. There's no reason why you cannot take your strengths and turn them into superpowers. So make sure you're consulting for both reasons. As much as is possible with your work, if you can limit your caseload, that's helpful too. And then also consider what we call professional self-care. This was on an article in the APA, and I'll make sure you guys have a link to my references as well, so you can see that. But she spoke about professional self-care, like, we know what self-care looks like at home: a bubble bath, right? Reading, a yoga class, long walk on the beach if you have a beach where you live. Those are all great ways to take care of ourselves, but we can't do those things at work, right? And so what can you do at work that mimics self-care? Can you take a break and make yourself a cup of tea? Can you turn everything off and go eat lunch in a courtyard, or at least not in your desk chair? What are things that you can do in the moment at work, or make time for at work that is self-care? And then also make sure you're checking in with your expectations, making sure that you are recognizing that if you are working with challenging populations, treatment can take longer. You can have maybe only small wins. Maybe people don't necessarily reach their goals, but they only move toward their goals. That's okay. That's great, right? And then also challenge other people's expectations too. Sometimes people need information as well, right? Like, I'm working with a really difficult population, which means the expectations that I have for them and myself are different. This is what I'm working with. I'm working with folks who have brain injury, who have substance use disorder. Providing education to people who you're working with as well can be super helpful. And then whenever possible, making sure you're practicing in the moment mindfulness. So doing things like reminding yourself of your intentions for the day, pausing and just reflecting on your emotions in the moment. And if you can, take a minute and just focus on your breathing before you go and you get, a new patient out of the waiting room. Take that 1 minute for yourself. So to summarize today, we really spoke broadly about treating comorbid TBI and substance use disorder and how challenging that can be for clinicians, for patients, for their caregivers, for the whole network, for everyone. We also spoke about how the symptoms with TBI and substance use disorder can exacerbate one another and affect the ability for patients with those diagnoses to engage and receive and benefit from typical treatment. So we spoke about how to modify that treatment and how wellness begins in group settings by really implementing the things that we know work well in group, and then making accommodations for things like cognitive difficulties and any identified problems that can happen as a offshoot of some of those symptoms. And then we also spoke about how to use consultation and referrals and additional assessments if some of those accommodations are not working for you. And last but not least, how clinicians can also work to just monitor how they're doing so they can continue to stay healthy as well when considering how challenging some of this work can be. All right. Thank you so much, everybody. I really appreciate everyone's attention. I hope this was helpful. I will hand it back over to Peggy.
Hi, Crystal. We did have a few questions in the chat we were hoping you would have time to address.
Sure.
Megan asked, would you suggest a closed group?
Yes, absolutely. I think closed group work better for this population because That flexibility of integrating new people into the dynamic is going to be less effective just based on some of that cognitive dysfunction and emotional dysregulation alone. Closed groups also give you the benefit of really kind of creating that group cohesion early, really building that group culture, getting a rhythm together, like how you go over rules in the beginning of the group, and things like that. So 100%, if you can get away with a closed group, I would do that.
Right, thank you. Holly asked a question and said there are lots of distractions when facilitating an SUD group inside a correctional facility. Limiting distractions in that setting is not always possible. Please address.
Yeah, that is such a good point. I think that we are doing so much more work around awareness and education for brain injury in correctional settings because the number of people with brain injury in correctional settings is so high. And brain injury also, ends up causing a lot of recidivism and people end up back in correctional facilities. And so it is very, very tricky and challenging when you're in a setting where you have so much stimulation. And so a lot of folks who have brain injuries or in correctional facilities or have substance abuse issues or any issues in correctional facilities, they become so easily overstimulated. So any kind of treatment, one-on-one or group, can be, just unwieldy. It's really challenging. If you can't change the setting, if you're in that setting, what I might consider doing is having everybody kind of start with something like a mindfulness activity to kind of get everybody really kind of calm on the same page. I would have an agenda. I would have the agenda visible. I would be keeping track of that agenda as we go. I think, like I mentioned before, when there is something like an interruption, whether it be a noise or yelling or anything like that, I would point it out so that it's not sort of sitting in the back of everybody else's head. And I would also ask the group too, like, hey, I know this is frustrating. I know that it's noisy. What do you think is going to be the most helpful here for you guys? It also gets some of their feedback on it as well. If you can't change the setting and you guys are doing meaningful work and everybody wants to come, lean into that and definitely get feedback to see what can be most helpful. That's a tough one.
Thank you, Crystal. Another one came from Hank. How much improvement can be expected while substance use is very active? And also, what is the protocol if a patient comes to a group intoxicated?
So I'll deal with the second one first. If someone is intoxicated in group, I would actually ask them to leave the group, gently and respectfully. If you're intoxicated, you're not benefiting from the group, and the risk of disruptive behaviors for other people is super high. So you really have to sort of make a commitment to one another in groups that we are going to, come as our best selves and really work together, not just on our goals, but everybody's goals. And then the first part of that, can you remind me of the first part of that, Peggy?
Yes, ma'am. It says how much improvement can be expected while substance use is very active?
Yeah, when substance use is very active, it limits so much, right? So it's a limiting attention, it's limiting learning, it's limiting the development and practice of those coping skills too, because people are still using substances to cope with things. So improvement is going to be minimal. And if you're including brain injury in that scenario, so brain injury plus SUDS, that active substance use is also going to impact neurological recovery. So if you are working with people who are actively using, I think the best thing to try to do is, make sure they're sober when they're coming in to as much degree as you can. And then secondly, really working on like MI-based groups to help them get to the point where change is, the thing that they're working on the most, so that you can have people coming in sober and staying sober so they can fully benefit from the treatment.
Thank you, Crystal. And we had one other question that came in early on from Phyllis. She said that her son sustained a traumatic brain injury and was in a coma for several days. She wanted to know if the effects of a traumatic brain injury could last a lifetime, and also if they could mimic the symptoms of ADHD.
So when people have moderate to severe TBI, there is a chance that they can have symptoms for the rest of their lives. A lot of people with moderate to severe TBI don't get back to baseline, which means they don't get back to their pre-injury level of functioning. So they can struggle with long-standing difficulties with cognition, with emotional control, motor functioning, sensory function, behaviors, all of the above. They may not absolutely struggle with it as much as they did when they first were injured, and over time, those symptoms will get better. Right now, we're seeing longitudinal studies where 10 to 15 years after traumatic brain injury of the moderate to severe severity, rating, that people are still showing signs of recovery, just slower than they did initially. So those first 2 years after brain injury, you're going to see a lot of recovery, really nice, robust recovery. And that's going to be fairly quick. But as you get to 5 years, 10, 15, you're going to see less recovery in smaller increments. But the possibility of recovery is still there, especially if people do things like go to rehab and just learn compensatory strategies, other ways of doing things to make them more effective and improve their quality of life. And yes, a lot of time TBI will look like ADHD because attention is a whole brain function. No matter where you're injured, TBI can preferentially impact attention. And so people will be more distracted. It'll be harder to stay on task. They can be a little bit more impulsive. Executive functioning can be impacted. So a lot of the times it can look similar. And if someone has an ADHD history and then has a TBI, those attention problems can be even worse.
Great. Thank you so much, Crystal.
Yeah.
Thank you very much, Crystal, for your presentation today. Thank you to AdCare Institute of Maine for hosting the webinar. Thank everyone here for joining us today, and I hope everyone has a great afternoon.